There's no damage. There's nothing showing up on the image. What is the reason that I'm having this pain? Which is the mindset that we and the research is moving away from. Like, a lot of pains in general don't directly correlate or have any causal relation to what we're seeing on images. So a diagnosis like patellofemoral syndrome, there is no clear mechanical cause. You're just having pain. So really, we just need to treat the pain. We need to treat the symptoms. We need to actually do a good assessment and find where someone's restrictions, where someone's deficits might be, and what might be resulting in this overload and this pain sensitization that's happening around the knee, because that's really what's happening.
Welcome back to another episode from the Optimal Body Podcast. I'm Doc Jen.
I'm Dr. Dom.
Doctors of Physical Therapy. And today we're talking about patellofemoral syndrome, or that front of the knee pain. Now, before we dive into all the nuances, outdated research, what you should be doing, what really helps, we want to know what you need, because we come up with these episodes based on what people request. So if you have other recommendations or suggestions or things that you're going through within your body that you just want a little bit more information, please drop it in the comments below so that we understand and we know how we could better help you. Of course, we have so many other videos, just movement related videos as well. So don't forget to hit that subscribe.
Okay, today we're talking about patellofemoral pain syndrome. We actually just got asked about this by a friend.
Yeah, that's what sparked the idea.
Yeah, realized that we had done an episode on this, episode 10.
Yes.
It's literally like the third week that we were doing our podcast. I sent it to her and I'm like, I'm not going to claim it's our best work.
Yeah.
Because it's one of our first podcasts ever. So we thought we'd do a little refresher on patellofemoral pain syndrome, what it is, and really what some of the outdated research, some of the myths on how to help patellofemoral pain syndrome, PFPS, and what you can actually do to start seeing results.
And one of the reasons we want to talk about this and reframe on like some of those older type exercises that still might be
still prevalent.
Yeah.
My mom recently was having knee pain and said that a physical therapist gave her VMO targeted exercises, which is when a younger physical therapist hears someone say like, oh, they gave me these VMO quad sets, we're like, that's so old school. You just know that it's something that they may have learned 15, 20 years ago or more, and, you know, like haven't gotten updated clinical guidelines or updated research on what to actually do for this.
Right. So we want to take you through like, okay, what is this really? And what could we really be doing about it to help long term? So if you're really, you've been struggling with that front of the knee pain, especially when you're doing a lot of movements like squatting and stairs or even just sitting too long. That's like the classic sign in the movies. If you're sitting too long, you get a little bit of an achy knee. Sometimes that could be patellofemoral syndrome. And it's kind of like irritable bowel syndrome is kind of what I compare it to, because it's just a kind of a catch-all front of the knee pain.
It's the IBS
diagnosis.
Of the knee.
It is.
Well, and I actually like diagnoses like this. A lot of people don't.
Yeah.
Because there's no damage. There's nothing showing up on the image. Right. What is the reason that I'm having this pain? Which is the mindset that we and the research is moving away from. Like, a lot of pains in general don't directly correlate or have any causal relation to what we're seeing on images. So a diagnosis like patellofemoral syndrome, there is no clear mechanical cause. You're just having pain. Mm-hmm. So really, we just need to treat the pain. We need to treat the symptoms. We need to actually do a good assessment and find where someone's restrictions, where someone's deficits might be, and what might be resulting in this overload and this pain sensitization that's happening around the knee. Because that's really what's happening.
Yes.
Is we have somehow through our daily activity or our exercise started to overload the knee joint. Mm-hmm. And we've done so in a repeated fashion in a way that the knee is now hypersensitive. It's like, you're doing too much with me. I've been feeling this overstress and overstrain for too long, and now I'm feeling pain. And then it takes a little bit less activity to feel that pain. So it's kind of this feedback where we keep loading the knee, it starts to become more sensitive, and then less loading gives us more pain.
Mm-hmm. And that's why we can see it a lot in adolescence. So like think 10 to 14 years old, where you're suddenly starting to see a lot more growth, maybe a lot more activity, but you're not used to that kind of load on those knees that are changing, right? So a lot of youths can complain of
those youths
can complain of knee pain, but also this presents in majority women, and we see it a lot in runners as well. So we're looking at like 23% of adults are going to complain about this, 29% of adolescents, and at some point it does become chronic because of what you're saying before, of the brain now starting to register this, and now it's become more of this sensitized area that we start doing something and it becomes chronic. And up to 91% of patients with patellofemoral syndrome really report continued pain at follow-up points between 4 and 18 years. I think that's a kind of a crazy stat to hear too.
Yeah, and I think the reason that this happens, and it's similar with things like chronic or persistent or recurring low back pain or SI pain, is we don't fully address it. Mm-hmm. You might find something that masks the symptoms. You might find something that helps bring your pain level down, and you're like, okay, great, I don't have pain anymore, and then you jump right back into your regular exercise or movement routine, and it comes right back. And we get into this cycle and this roller coaster, which is actually like really crazy for our brain to figure out how to process, because they're just like, wait, I didn't have pain, but now you're overloading me in the same way that caused this pain. Mm-hmm. And so then our nervous system starts to get confused, and then that's why it starts to develop this pattern, and we feel it over and over again, and we fall back into that same pattern easier because we continue to do the same thing. So how do we start to edge out of that cycle?
Well, and that's why, going back to what you said before, that it's an overload syndrome, right? And so we have to understand if we're doing something that's overloading the system, we eventually have to get back to loading progressively over time. And if we're not providing enough stimulus, then we're going to eventually get back to our regular activities, and it's going to go right back. And that's why in traditional rehab, a lot of times what we see is that the patients are not being progressed enough, right? We're sticking to some old school protocols. We're doing things that have patients lying on their side, on their back, barely getting up and standing, and barely loading their bodies, and then saying, okay, go right back into what you were doing before, and we're going to expect not to see them again? That's kind of crazy.
3 sets of 10 of this for a couple of weeks, and then jump right back into your exact activities.
It doesn't make sense.
When it's like a quad set where you're essentially barely putting any load through the knee, and then get right back into running. It doesn't make sense. You're not going to train that knee to be able to handle your regular activities. And that's where we go into myth number 1. I mentioned this VMO exercise.
So what is that?
So the VMO is the vastus medialis obliquus, I believe. Something along those lines. And it's one of our quad muscles. It's one of the 4 heads of the quad muscle, and it's on the inside. It's this teardrop that you'll see if you flex or extend the knee, I guess, to flex the quad. On
the inside of the knee. To
activate the quad, really the inside of the knee.
But it's small.
Well, it's the quad, so it's big, but it's a small player in the overall quad, function. And the original thought and what people would say is like, oh, you're having this because your patella is tracking laterally, or you don't have like smooth patellar tracking. And they thought, okay, let's train the inner quad muscle to stop that patella from tracking laterally. And again, from research, from looking at biomechanics, we know that there are a lot of people that have all sorts of different variations in how their patella tracks and no pain.
And we have a podcast that we went into more detail about that too.
And so again, we can't any longer look at and say like, oh, your patella tracks a little bit laterally, that's why you have pain. No, I call BS.
Well, and we can know now that we cannot isolate just the VMO from the rest of the quad.
Yeah, it doesn't do anything anyway.
So sure, we are doing exercises that are addressing the quad, but it's not just addressing the VMO. And so sure, some of those exercises are going to be beneficial, right? But if we're only doing ball squeezes with a leg extension hold and focusing just on trying to do that, we're missing a greater picture of what we need overall.
Okay, so now getting into what the evidence actually says. And I think that we fall into a few different buckets. We brought up our friend. She was reaching out to us about her kid who lands exactly in
The
adolescent group of people, like their body's growing fast, they're getting into activities, they're excited to be doing all this new stuff.
Well, and both of his parents are hypermobile.
Yeah, both his parents are hypermobile, so he's got that playing against him as well, where he's growing fast, his muscles are growing fast, they're putting a significant amount more force through all of his joints. But knowing that hyperlaxity and hypermobility runs in his family, I'm guessing that he doesn't have the greatest control through a lot of these movement patterns that I'm sure, and knowing this kid, I'm sure he's just throwing his body through all of these movements. It's kind of like a controlled fall around the field or the court or whatever he's doing. Again, he could still be an amazing athlete. That doesn't mean that there's probably underlying control issues with why he might be overloading his knee. That's one bucket. Next bucket would be the people, like you said, like runners, people who do a repetitive activity, who don't have a lot of different cross training, who might be stiff in the hips and the ankles, and they don't focus a lot on mobility, and they just start to develop this pain because of that overtraining along with the overloading.
Yeah. I mean, and what we see technically from research is like over and over again, the key of what seems to be helping protocol-wise is knee and hip strengthening together. Not just doing knee strengthening, not just doing hip strengthening, but when we do hip and knee strengthening, working on things like getting back to endurance, working on things like getting back to just being stronger overall in your lower extremities to support your leg and support your knee, and then getting back into more plyometric dynamic type work, especially if we're talking about an athlete who wants to go back to loading in a dynamic way. Like this is what becomes more superior when we're talking about what's going to really help long term.
Yeah, if you're seeing a physical therapist as an athlete, as someone who, whether you're playing competitively in like basketball or something, or just playing like rec leagues, and they don't progress you to the point where you're off the table doing standing movements, squats, lunges, and then progress further to seeing how you do landing from a jump, bounding from one leg to another, and how you control that. Those are the places in those activities that you're going to start to overload the knee joint.
Right.
Not when you're laying on a table doing a quad set or a leg lift or a hip exercise or a clam or something. Like those aren't the points that you're overloading your legs. Yes, some of those exercises might help with activation that then can translate into doing standing exercises and then to plyometrics. So there is a place and a value for those, but we need to see that progression.
We have to. And there is research that we have that shows that hip weakness, especially in like the glutes that bring the leg out to the side and rotate the leg out, are strong contributors to showing people would have patellofemoral syndrome.
And then another component of this, when you are in pain, because we're talking about squats and lunges and talking about plyometrics and bounding exercises, and those initially would likely be aggressive for a lot of people who have active patellofemoral pain, which is why you don't start there. That's why you do start on the table and look for those other mobility exercises, mobility restrictions about the hip and the ankle, doing some of those activation exercises, and then discussing load management, where if you are a runner and you're running 4 or 5 times a week, like, okay, what can we do? Can we replace that with rowing or biking, or can we just significantly decrease the load to 50% or less, to the point where we can get those symptoms to calm down so that we then can build back up? When you're playing the pain game, you really have to trick the body into desensitizing the area. And you're not going to be able to do that if you just completely, continue your exact exercise regimen or activity.
And we have to know, like, as you start to progress, there might be little symptoms of pain that pop up along the way.
Yes.
It's not bad. Pain doesn't equal damage. And I think understanding that as well, it's just a reminder for the brain, like the brain's trying to protect you, right? So it's like, oh, is that too much?
I'm reaching my threshold.
Right. So we're listening to the threshold that we're getting, but we want to meet that to a certain degree. We want to tap into that, because then we know that we're putting enough stimulus, enough load, and we're not just staying in this pain-free quad set clamshell place. We have to be able to progressively tap into that a little by little. So we're not going after like 10 out of 10 pain, right? We're not going for max pain, but maybe we have 3 out of 10 pain as we're doing some new exercises, and it's starting to wear down the more that we continue to do it. So it's retraining the brain to also respond to that pain signal and reminding the brain, this isn't bad, this is okay, and we are strong, we're resilient, we're building it back up.
And something that can always be a component of a rehab program is different adjunct therapies, or
that help control pain symptoms,
or what we like to call passive treatments. And that's anything that's any sort of hands-on treatment, any sort of mobilizations that a physical therapist, athletic trainer, chiropractor might be doing, any sort of kinesio taping, patellar taping, dry needling, Graston techniques, using a different type of footwear, to just, in the meantime, using those techniques to modulate the nervous system, bring those pain symptoms down, so that you then might be able to do more of the corrective exercise stuff.
And I love that foot orthoses was actually in that with helping to control pain, right, in the beginning, because that is a signal that tells us, okay, if I can change the structure of what my foot is doing, then maybe I can help my knee as well. Maybe
that loads knee differently, which tells us
foot strengthening.
Doing foot strengthening can impact the knee. Bonkers. Okay.
Right. And so like, even when we're starting to talk about some of these exercises, like, can you do it more in barefoot shoes or barefoot altogether? Like, especially when we're starting with more of like those baseline, easier type exercises that kind of help to modulate those pain symptoms in the beginning. So can you do it in a more barefoot environment so that you start to train those feet as well without shoes?
Yeah. And what we list off for like potential exercises to do is not a comprehensive list.
No, there's so much that
we don't want to give you 100 exercises for the foot, knee, hip, core.
I know.
That you can do. So we're going to focus on a few different things. But the 3 specific phases, and we've kind of outlined it throughout this podcast. One is activity modulation and pain reduction.
Yeah.
And starting to get activation back in those knee muscles around the knee, muscles around the hip, addressing the hip and ankle mobility restrictions you might have. Phase 2 is then gaining back the strength and control in slightly more dynamic movements. And then phase 3 is when we're getting back towards those more, I don't want to say aggressive, but like ballistic movements.
Yeah, more dynamic type movement.
Loaded squats, lunges, deadlifts, and then dynamic stuff like plyometrics.
Yes, exactly. And so when you're thinking in the beginning, it's like a lot of isometric holds are going to be good. Sometimes people think of that like quad sets. So that could even be like kicking your foot into like a resistance band and just holding in all different positions on your back, seated. Doing just straight leg raises, kind of laying on your back, controlling from the core and the leg and kind of lifting, doing a side clamp. So a lot of these things, bridges, could be really good to help just get you back into some activation without putting a lot of tension and load on the knee.
Like being able to feel the knee move and activate the muscles around it without having pain is like pretty powerful to the brain, to like at least have a time that you're sitting down every day and saying, hey, I'm moving my knee and I don't have pain. Right. That's like one of the first steps in starting to train back that nervous system.
Just adding in what you kind of touched on before, because that's not necessarily, this isn't part of the evidence and what they look at, but we strongly recommend, like he said, working on mobility in that phase as well. Yeah. Like when you open up the knee, when you get better ankle mobility, you take pressure off of what's only happening at the knee, right? Because if I bend and I lift and I can hinge more from my hip and I can not put as much load on my knee, if I can bend my ankle more so it doesn't put as much tension on the knee, like it just makes sense to open up these areas above and below.
Yeah, so doing different dorsiflexion stretches, doing active dorsiflexion like heel raises of sorts, and then doing a hip 90-90. I bet if everyone assesses their hip internal rotation, hip external rotation, and hip extension, there's probably going to be some deficits in most people. I'd put money on that in one or more of those. So doing a hip 90-90 switch and starting to like reclaim some active range of motion around the hips. That's where we're going to start to learn once we get standing, like, okay, I do have this ability around my hips a little bit more that can help take some pressure off the knee.
And then we go into like this strengthening phase, right? So now we're looking at more loading. We're getting off the ground, we're loading more. So that could even be just like step downs. step ups, right? So we're controlling how we're moving from the hip to the knee in a controlled step up. We're controlling how we're eccentrically loading across the knee and across the hip as we think about stepping down really slow and you start to feel something different, especially if we're not letting the hip drop or keeping the knee in alignment. We're kind of looking in a mirror and saying, okay, can I control this from my hip down to my foot? Doing things like wall sits, doing Bulgarian split squats. So these are all really great ways to start loading into the knee.
And we really like, there's always some sort of squat variation or squat with a band around the knees. I prefer, in this case, to do like a heels elevated variation of a squat, because that's going to put more load through our knee and through our quad muscle. And starting somewhere like that, and then progressing maybe to something like the Bulgarian split squat, where, okay, now you're needing to control all the weight on one leg and understanding how my body controls that weight on the way down and up. And then phase 3 is moving into more of the sport specific type of stuff, or increasing load on the strengthening exercises that you were doing in the last phase, and then moving more into plyometric stuff.
And increasing load can also mean you're increasing your range of motion. So maybe at first you were doing heels elevated squat only to like halfway, right? And that's all you felt like you could tolerate. Now you're going a little bit lower. You didn't necessarily increase the load, but you increase the range of motion that you're feeling more comfortable with. So that could also, change and be a part of progression, is range of motion, slowing down the tempo and increasing the load, and then getting back to, can I land well? Can I do single leg hops? Can I jump? How does that feel just to take off of a leg or do some bounding? So now this all can get really confusing of like, okay, so I have to do a million things for my knee because I have to work on my foot, my hip control, my strengthening of my knee, then progress it over time, then it can sound overwhelming. And if this is you who's been stuck in this pattern of, that 91% that has that reoccurring or chronic knee pain that continues to pop up, we have a knee plan on Gen Health. It's 5 to 15 minutes a day. By phase 3, there are going to be longer days because we get back into strengthening and loading and putting more load across the knee. But I'm guiding you through the entire thing, whether it's mobility or just getting back into some activations to get stronger across the knee and across the hip and foot. We have all of that in the knee plan on Gen Health. So I'd highly recommend at least starting a free week and see what it does. Like, you have the accountability, it checks off every day, and just showing up, doing something different and being consistent can go such a long way.
And it's a 30-day plan. So this through phase 3, that's 90 days. And by the end of the first 30 days, you might feel like, okay, these basic exercises are just that, feeling too basic now. Well, great. Then we'll progress into phase 2, where you're going to be doing more standing, more loading. Phase 3, where you're going to then work into strength training. And this is the process, especially if you're somebody who's had a recurring or persisting issue. It does take time. And that's one of the unfortunate realities, is that once we've been in pain for an extended amount of time, it's likely going to take a good amount of time to retrain our body's understanding of how to operate, understanding of how to move in a way that joint feels comfortable with, that's not going to trigger off those symptoms that have always been living just below the surface. So knee plan will be amazing to get into, and it helps follow a very similar process to what we just outlined. Thanks for listening in to another PT Pearl all about that knee pain, patellofemoral syndrome. Comment below, did you learn anything? Have you had somebody tell you some of those old myths and outdated methods of treating this type of symptom, or did you do something different that worked for you? Let us know below, and don't forget to subscribe and hit the notification bell before you go.